And y'all are going to hear me refer to Nathan a lot tonight. Nathan Jackson is our communications manager, and he is making things run for us. That's him waving there. We also have enabled closed captions for this meeting, and you can opt into that. So when you're down in that little menu at the bottom of your screen, you're going to hit the More button on the menu and select Subtitle from your individual Zoom controls. If you have any questions about accessing the closed captions, go ahead and put them in the chat, and Nathan can help you out. So thank you all so much for being here and being with us for Compass Housing Alliance Navigates. So for those of you who are new, Navigates is a speaker and conversation series designed to bring our community together to learn, collaborate, and foster understanding by exploring the complex, intersecting issues underlying homelessness and the affordability crisis and what we can do about it. My name is Liz Gerard, and I'm the Director of Advancement for Compass Housing Alliance. I've been with Compass for 8 years and dearly love our work. I work on the team that helps communicate about our mission and promote the organization. We really believe that education and community engagement is a core piece of our work, and Navigates is part of that. You may have joined us in March to hear from Professor Josephine Ensign, or in June to hear from mental health professional Erica Spongberg. Welcome to you all. I see staff, I see members of our board, our ambassador council, supporters, and members of the local community. We really just hope that tonight's presentation is helpful and inspiring to you. Tonight we have with us special guest, Dr. Simha Reddy. He will be joining us as a well-respected healthcare professional who specializes in the intersection of healthcare and homelessness in our city. He has been working in the field ever since he completed his internal medicine residency at the University of Washington in 2012. And currently he's the medical director of homeless primary care at the VA of Puget Sound. So big job. He is in the community caring for people experiencing homelessness and the traumatic impacts of homelessness and health issues on a daily basis. I, in fact, met him in our hygiene center on my very first day of work about 8 years ago. He doesn't remember it, but I do, because everyone knows Dr. Reddy, who works in the provider world, and we're really excited to have him here tonight. Tonight, he will be sharing information about the close connections between health and homelessness, insights about the challenge that people experiencing homelessness face with healthcare, the intersection of aging and health in this population, and about some of the unique challenges facing veterans. As far as the engagement piece of tonight, like I mentioned, the chat is there. Please feel free to add your questions in the chat as we go. We'll have plenty of time for discussion at the end, and Dr. Reddy's gonna present at the beginning, and I'll break in if there's some questions that can't wait. Otherwise, we're gonna have hopefully a rich conversation there at the end. We hope you participate. First, to get things off, we have a poll question that we want to hear your feedback on. So Nathan, go ahead and launch that first poll. And as he's doing that, I'm gonna give you a sneak peek of the question. Oh, there it is. Besides housing, what do you think the biggest barrier to accessing healthcare for people experiencing homelessness? What do you think is the biggest barrier? So go ahead and put your vote in. And once y'all have had your vote, then we'll kind of give you some insight on what poll we see. All right. So on our end, we're seeing some popular answers are difficulty contacting health services. So just difficulty navigating what is already a complex medical system. Underlying health conditions. So perhaps people are thinking that folks who experience homelessness have higher rates of health concerns. And then we have a couple votes for living conditions and then access to reliable medication. So most of y'all are picking, the accessing healthcare services from the beginning, and then, people who experiencing homelessness who may already be quite ill or be ill because of the experience of living outside or surviving outside. So thanks for participating, everyone. I'm going to go ahead and kick it over to Dr. Reddy for his presentation.
Liz, thank you so much, and to Anne and Nathan as well, and actually all of Compass for inviting me today. Really excited to get a chance to talk about that intersection between health and homelessness. Um, and actually, as I look at this poll, as painful as it is to see that, difficulty contacting health services is number one, I don't think you're wrong. I mean, I think I would probably have picked those same things, difficulty contacting health services and your underlying health as being really painful and really affecting our uh, people's ability to access care. Um, but I'm going to turn that off for a moment. Before I jump into it, I do want to actually, I'm sorry, I'm trying to figure out the all right. Can you guys see it now?
Not quite yet.
Oh, my apologies. Right. I actually have to share my screen.
No worries. It's a friendly crowd.
And they had me show up 15 minutes early for a tech check, and I still can't quite figure it out, even though I seem to have gotten it before. All right. Where's my Zoom?
No problem. Let us know if we can be of help. Otherwise, we'll leave you alone.
I appreciate it. All right. How about now?
Now is great.
Awesome. We've been doing this for 2.5 years with the pandemic, and you'd think I would have figured out Zoom by now, but there you go.
I muted myself earlier and didn't know.
Well, anyway, I'm super glad to be here. I do want to point out that I don't have any financial conflicts of interest in giving this presentation. I do think it's also important, though, to note my other affiliations. Like I'm a clinical associate professor with the University of Washington. I work at Puget Sound VA, and I'm on the implementation board for the new King County Regional Homelessness Authority. I say that mostly to share that I am not wearing any of those hats today. Like the views today are really just mine alone. I also should share that I have a long affiliation with Compass. For the last 10 years, they've been kind enough to open up their spaces to me to let me come visit with veterans in their hygiene center, their day center, their permanent supportive housing units. In fact, I was there today, and one of our amazing case managers I get to work with is here today as well. So big thank you to Compass, not just for inviting me today, but for all these past years too. You do amazing work. All right. So this is what it can sometimes feel like, right? Like if you're a patient who's experiencing homelessness and you show up to your doctor, and this is, they don't say it out loud, but this is more or less the advice, right? And it's really painful, both for the patient, but also for the doctor or the nurse or other provider, right? Because they know it's not feasible. So I want to explore that a little bit more. Incidentally, as I go through the talk, I may share a handful of stories or examples. I want to be clear that if I do so, I will have changed all of the details. When I interact with a patient, that's a very private interaction, and any story I share is one that is a composite of multiple things that have happened. So I'm going to touch on health and homelessness, how those two intersect with each other, some of the barriers to healthcare, just a general example. And then I want to talk a little bit about the effects on healthcare systems, right, of homelessness and our affordable housing crisis, then move over to questions. I tend to be pretty long-winded, so I am going to just try to shut myself off at 7, and Liz, feel free to just jump in and stop me anytime. When you leave the talk, though, the things that I really hope that you take away are things that are extremely obvious, but I think are still important. Number one is that homelessness really does kill people. Like the being outside um, takes people's lives. It also makes people age sooner. And the strain of being outside is really, really wears on the mind and the body. And this crisis is really breaking our healthcare systems. And then finally, I'll just share my belief that I believe we can do this better. Anyway, talk about homelessness and health. So the life expectancy for somebody in King County is around 78 years old. So pretty good. It dropped a little bit during COVID, but that's kind of roughly about where we're at. What would you guess is the mean age of death of someone experiencing homelessness in King County? It's not exactly the same thing as life expectancy, but it gets at a similar question.
And we're going to do that as a poll, right?
Let's do that. Yeah.
Yeah.
Because y'all are so tech savvy.
So Nathan's going to pop up a poll. We thought it might be interesting to hear your thoughts on what you think the mean age of death is for someone experiencing homelessness in King County.
Remember, life expectancy is 78. So it looks like some of you think it takes 10 years off of people's lives or more, 20. Okay.
Yeah, we've got about over half of the crowd saying less than 55, right. About a third. Gotcha. Yeah.
So that this condition, right, like more so than diabetes, more so than heart disease, more so than anything else, is going to take off 10, 20 years of your life. And this crowd is fairly cynical in that they think that, more than half of you think it's going to be less than 55, and you're right. This data is a little bit old, but it corresponds to data that you see in multiple sort of other studies in other cities, communities across the world and our country, where people tend to die in their early 50s while experiencing homelessness. And, if you were to compare it against other diseases, right? Like if you compare someone experiencing homelessness against somebody who is of a similar age, but has a stable home, even if they're in a shelter, their likelihood of death is 3-fold higher. And if they're outside, it's 9-fold higher. So there's basically, there are very few medical conditions that take people's lives in this way. Now, how does that happen? So first of all, let's start with the other side of it. How does poor health lead to homelessness, right? So it can happen in a lot of different ways. Our medical system bankrupts people a lot. And that can lead to foreclosures, lead to people not being able to make their rent and ending up on the street. You throw out your back, you develop hip arthritis, you have a major depressive episode and you can't work. And if you don't have much of a safety net, well, you're on the street. People who have people with severe mental illness, PTSD, substance use disorders, traumatic brain injuries, even mild dementia, all of them are more likely to become homeless. And I think of it, there's a lot of different ways of thinking about it, but given the system in which we live, in which we have an affordable housing crisis where no one can afford the rent, basically, someone is going to be homeless in this community. And the people who are going to become homeless are the people who are most vulnerable. That means people who carry the weight of racism, people who've had traumatic childhoods, and people who struggle with both physical and mental health disabilities. So none of this is shocking, but actually one minor note: about half of people who are experiencing homelessness in one study reported having had at least a mild traumatic brain injury in the years prior. Like your ability to deal with a crisis or challenge can sometimes be impaired and increases the risk of becoming homeless. And the flip side, right? A few of the ways that homelessness can worsen health. The rates of physical and sexual violence are off the charts for people of all genders. I will say that, it is only in this job that I've ever seen a machete wound. Like, it is very dangerous out there. I think we all are aware of sort of the exposure to the elements. If your feet are wet and cold, you can easily develop trench foot, peeling, painful feet, severe infections, that kind of thing. It was only, 3 or 4 years ago, I think, where during a point in time count, a woman was found deceased out of exposure outside. And, anyway. Other issues, infection risk, especially if you're living in congregate shelter, which thankfully has been slowly fading away and moving more so towards a non-congregate approaches to care, to safe shelter. If you've got diabetes or you need to be on a low salt diet and you don't have much in the way of food choices or ability to cook food, these are issues. And then you can get caught in this terrible cycle, right? Like, maybe you struggle with mental illness or substance use disorders beforehand, but being in a shelter or being on the street is not the way to heal. And, it is very, very common for people to develop a mental health disorder while they're outside, while they're on the street. You're dealing with the ongoing traumatic experience and developing depression, anxiety, using meth to stay awake through the night. I mean, that is like fairly common that people will try to do that. So homelessness really does make things harder. And, if you struggle with the if you struggle with a health condition of your own, think about what it takes to manage it, right? If you have diabetes, all the work it takes to make sure that you've got your insulin, that you've got access to your insulin needles, that you've got a good diet, that you're able to get exercise, that you're able to make it to your appointments on time. All those things become exponentially harder. And then, in that initial poll, those barriers to healthcare, right? And those barriers are not just logistical, like, can I, getting transportation and such. It's also about stigma, right? Many people who are experiencing homelessness report that, when they interact with the healthcare system, just like when they interact with a lot of other systems, they're often faced with discrimination, or it can be hard to be the only person in the waiting room pulling a suitcase, or not having been able to shower in a few days. And if the person at the front desk is kind of dismissive, or the doctor doesn't want to shake your hand, pre-COVID times, all of that makes it harder to feel like you're welcome. And then I want to comment on sort of aging and homelessness in particular. So here in King County, based on the last Canvassing report, a quarter of people are over the age of 50, and I think it was like 8 to 10% people were over the age of 60. It is really, really common, and any of you working in emergency shelters and other frontline services, I'm sure you are routinely running into people over 75, even into their 80s. Your Social Security check does not go very far in this community, and it is really, really easy, if you don't have a good safety net, to end up on the street. I remember being at one of our shelters many years ago at this point, and a elderly woman, turned out she was in her late 70s, walked up and she was just chatting a little bit. And what had happened with her is that she had gone to her eye doctor. Turned out she had glaucoma, prescribed some drops. Her insurance didn't cover it, and she didn't quite know how to deal with that, so just paid out of pocket, which meant her next rent check bounced, which meant that she, despite having been a tenant for close to 10 years, was soon evicted. I mean, this is the reality, right? That there's not a lot of leeway given to people. And the other piece of this is the effect of homelessness on people's sort of physiologic age, right? You can be 50 years old, but have the body of a 70 or 80-year-old. And in fact, when they did a study of kind of older people experiencing homelessness in the Bay Area with a median age of just 58, though, like still fairly young. Over a third of them really struggled with what they call a basic activity of daily living. This means like having trouble getting to the bathroom or going to the bathroom or dressing themselves. Like that is a pretty serious issue. And over half struggle with an independent activity of daily living. This means being able to go shop for yourself or, cook or clean. And so like when they really looked at sort of like these geriatric syndromes, right? Like health harm people falling and weakened and other things, they were really, these rates were really similar to people who were in their like nearly 80. So it's not just about taking decades off people's lives. It's like you were adding decades of strain and stress to people's bodies. By the way, Liz, I can't see the chat. If there are questions coming up, just let me know.
Yeah, thanks. I did want to share one comment from
Please.
Sue Nichols from Interfaith, who just personally shared that Sue's clients are overwhelmed emotionally with the anxiety at interfacing with the healthcare system, right? Calling that office, well, what will they say? What will I say? How will I say it? Will I remember to say everything I should? And, when asked for a residence, what will I tell them? It's just a personal validation of what you were saying you see all the time, I'm sure.
That is, thank you for that comment. That like something that people don't even necessarily think about, right? Like how hard could it be to just call up the office, right? I will say that, I've struggled with depression myself over the years, and I remember how hard it was to just call up a clinic office and ask for an appointment. That was impossible for me. My wife needed to help me do that. And that anxiety of like, what are people going to think is huge. There's this idea of trauma-informed care, which I imagine, everybody at Compass and many other people on this call have heard of. And, this idea that you don't know what somebody has experienced before they get to you, right? Like you have no idea what happened on that bus ride over or what happened in their childhood. And you don't need to know, right? Like they don't need to share their trauma with you. But to treat people in a way that makes them feel truly safe and welcome, and that is a hard thing to do, right? And like one of the goals that I have, like when we, and this is something I work on a lot, both with my like interns and residents, but also with myself, is like to make sure I think of this visit as earning the next visit, right? The goal of this visit is to get the next one. And that's not just about the personal interaction. It's also about how hard was that for that person to get there and feel safe, right? Like that front desk, the phone call, when somebody picked up that phone, were they really warm and welcoming? Like that could make all the difference in the world. Anyway, this is me getting long-winded. I'm going to stop and move on.
No, it's so true. Just even with when people walk through the front doors of the Compass Center to go to the day center, right?
Right.
That takes a lot of courage.
Absolutely, 100%. I want to run through like a quick example, right? There are many, many, many barriers to care, but I'm going to share sort of a composite example. This is somebody who's in their 50s, has cirrhosis of the liver, and in this case, it means that they build up a lot of fluid in their gut, and they can develop liver-related confusion, hepatic encephalopathy. But when they take their meds, they're fine. And let's say you're that person, and you were doing well. You are like not using substances. You are getting your life back on track, and you decide you're going to reconnect with your girlfriend. Like she invites you back here. You move from Spokane, and when you get here, you're surprised to learn that she's using meth, and you begin to worry about your own recovery. And your options are, hey, do you try to move out to a shelter or find a spot on the street to keep away from using? Or do you stay with her and know that there's a good chance, right, that you might start again? I mean, if it was me, these are pretty reasonable choices, but let's say you choose to move out to a shelter. And you decide to stay at a, drop-in congregate shelter because everywhere else is full. The medications you take, one of them makes you pee like a racehorse to make sure that you don't build up fluid. And the other one makes you have diarrhea. It does that on purpose to help you get rid of ammonia and other toxins. and you need to take those both multiple times a day. And are you going to use this communal toilet, or are you going to try to carry your stuff all around the street and try and find a business that's going to like open their doors to you? Or maybe you say, hey, actually, I'm feeling okay right now. I might skip my meds. If it was me, I would skip. I mean, I'll tell you that right now. But you start to have consequences, right? Your legs start to swell up, which means you're more at risk for infection, and then you start to get an infection on your skin. So, like you're talking about with your clients, like, do you try to call a local clinic? You've only got 10 minutes left on your phone. You spend it on hold and then try to make an appointment for 2 weeks out? Or do you go to the ER? I think there's sometimes this like, people blame folks for using the ER. Like, why are you misusing the ER for simple things? But in actuality, like, it makes sense. People make good choices given the context that they have. And in this case, let's say they get seen in the ER, the infection's treated, they're given an antibiotic, and you're told to go home and follow up with your primary care doctor who you don't have. Turns out that bacteria that was affecting you isn't affected by your antibiotic. ER wants to reach you, but he can't get you on the phone. Your leg starts getting worse. You start getting more confused because of liver issues, and infection makes that worse. And you can't get to the hospital because, we got rid of the free ride zone here in downtown Seattle some years ago, and we don't have bus fare. And you're worried about getting a ticket. So you just sort of linger. And eventually you get so confused that somebody calls the medics. Thank goodness. Get them into the hospital where you end up having to stay a couple days. By the time you finally get out, there's nowhere to go. And so what do? I mean, and you get caught in this cycle again, right? And this is like one particular example, right? Everybody has hard choices, whether it's you're a parent with a child who's immunocompromised and getting chemotherapy, and you don't live in Seattle and you don't have a place to stay, or it's somebody who's elderly and like, doesn't have anybody to fall back on. At every stage along the way, people are faced with really tough choices, and I think generally people do the best they can. Finally, I wanted to just touch on, I talked a lot just now about sort of like the effect of homelessness and health and how those interact with each other, like on individual health. But now I'm going to be selfish. I'm going to talk about how it affects, people on my side, on healthcare systems. So if your patient is homeless, they're more likely to end up going to the ER, kind of like we talked about, right? If they end up staying in the hospital, it's more likely they'll have to come back to the hospital after they get discharged because they didn't get all their, they weren't able to afford their medications, or they didn't have a safe place to do their wound care, all the things. And then, a longer length of stay. My father-in-law had a bad infection and was hospitalized for a period of time, but then was able to go home with home health, right? A nurse came out and like gave him antibiotics by vein every day for like 2 weeks, and then he was good. How do you do that if you don't have a place to go? Right? There are a total of, I think, 34 medical respite spots for all of King County. And and actually, in thinking of that length of stay, if you were to ask any hospital in this area, like I'm not talking about mine in particular, I'm talking about every hospital in this area, I would bet cash money that there are people who have been there, patients who have been there for more than 6 months and maybe over a year, just waiting to go someplace. Not because they need to be in a hospital, but because they don't have another place to go. There's no adult family home that can accept them. There's no assisted living. Maybe they're on methadone and a nursing home won't take them. Whatever the reason, like, these things happen. And I don't know if you're aware, but like some weeks ago, sort of the unthinkable happened. Harborview Medical Center, our county safety net hospital, went on diversion, meaning that they only, for a while, they were taking only the very sickest people, and other people had the medics had to take their ambulance, had to drive them to other hospitals if they didn't meet certain criteria. And that is kind of unheard of for Harborview. It has always been there for us, and will continue to be. But when you looked at it, I mean, they are consistently operating in, I don't know, whatever it was, 20% over capacity at any given day. And when you look at who's actually in their hospital, I think it was something like 15 or 20% of the people in the hospital just are waiting for placement. That's crazy. That is absolutely crazy, right? And that is not like that. If a hospital becomes someone's home, that is not good for the hospital, but it's definitely not good for that patient, right? Like that is not where someone with dementia should live. Anyway, so it is difficult to safely discharge people. And this leads to this issue of kind of moral injury and burnout. There was one of my so some years ago, there was a ear, nose, and throat resident, so a surgical resident doing their residency, and they took care of someone who had a throat cancer and needed to do laryngectomy, and this person needed to be on a liquid diet going forward, at least for months going forward. And so they stayed in the hospital, got their surgery, healed well from the thing, and then discharged to a shelter, sort of unable to talk and unable to take anything but liquid food, which was not available where he was going. And so that person was sitting there essentially starving, like in a shelter, because they could not get food down, and he did not have access to liquid food. That resident apparently, had done all of the right steps by the book, right? Like had done the surgery well, had like done the post-op well, had like discharged the person when they were safe to discharge, and then just was having nightmares, like with just staying up nights, could not think of anything else because he was worried about this person, and told his wife, who happened to be friends with somebody who was running this brand new palliative care service at Harborview, specifically for people experiencing homelessness. And so at the end of the day, the story turned out well, right? That the patient ended up getting connected to care. They found a solution, like it worked out. But those are decisions that have to happen essentially every day, right? Like, do I admit this person who's got some mild dementia into the hospital, even though they don't really need it, but they also aren't safe on the street? But I've also got like 10 people backed up in the hallway in the waiting room, and they are all like having heart attacks right now. Like, what do you do? And I think there's this issue, like people talk about burnout a lot, right? And I think a big piece of burnout is this idea of moral injury, where you are faced with suffering and then you can't do anything about it. And I imagine that's a feeling that many people on this call have felt before. It's an awful feeling. And because our system as a whole, like our community as a whole, has not solved this problem yet, the people who suffer most are the people experiencing homelessness, but it causes knock-on effects to the rest of the community. Anyway, I'll stop being selfish and talking about us as medical providers. One last thing. I will say the benefit I get, right, is as a primary care doctor, I get to see when things are going badly, but I also get to see when things go well, when things turn around and people show back up and get housed and are feeling okay. That's not necessarily true of an ER personnel or medic or a firefighter. They only see people at the worst moment in their life. And if they see that again and again and again and assume that it can't change. I mean, and so it takes a really special kind of person to be in that role and to remain hopeful. So I have the luxury of being able to see the other end. When people stop showing up, maybe it's because they're actually housed. So there are other things I can talk about, sort of veteran care and other issues, but I'm actually going to stop there because and just stop for questions, if that's okay, Liz.
I do have a question. Hello?
Yeah.
Go ahead.
Yeah, so I'm a veteran, and I have a lot of friends who are veterans, and who have to navigate the VA system here in Seattle. And a common theme that I've heard is that they just don't feel heard from medical staff at the VA, that they're just kind of abrasive. They just don't really take their concerns seriously. Like, it's all about like just giving them pills to just calm their symptoms down. And I don't know, how do you feel about that? Because I'm a veteran too. I use the VA. I have a lot of friends who use the VA, and like that's just kind of like what a lot of people say about providers who work at the VA, that it's just like, let's just give them some pills. Let's just, what do you call it? It's a training facility. Let's just, like being used as like guinea pigs. So how do you feel about that?
Sure.
I mean, that's just my experience and like what other vets have told me.
It's a hard one, right? Because like I'll start by saying this. One, I'm sorry, like you shouldn't feel like that when you come for healthcare, and your friends shouldn't feel like that either. And that's bad care if you're not feeling heard. It's long and short of it. But I will say that there's a reason I work at the VA, and that I work at this VA. So I've been doing it for 10 years now. And at this point, like, I honestly can't imagine working anywhere else. And I know that sounds kind of crazy, right? Like, because the VA sometimes has this reputation for being bureaucratic and hard to access, or maybe dismissive in this case, right? But I don't know that that's the general experience, or I don't know that that's the usual experience or the typical experience. I'll share the experience from my end, right? Which is that the VA is the only place I know of that if my patient needs a home, we can figure it out. It might be kind of hard, and it might take some step, but we can make it happen. It's the only healthcare system I know of where if you show up and you're seeing your primary care doc or something, and you need to see a psychiatrist or a psychologist, you can see them the same day. It may not be perfect, may not, it's not going to solve the problem entirely, but at least you connect, right? Those are two things I don't see in other places. The people that I work with, at least at the Seattle VA, for the most part, it feels like they're part. Most of the people I know who work here feel like they're part of a mission, and that feels good to me. That like our job is to serve you, like you served our nation, and then our job is to make sure things are okay for you. So I can't speak for the VA as a whole, like that's not my role here, but as an individual person working at the VA, I think there's a lot of good stuff that happens here, and if we're screwing up, then we need to know about it, and we need to get better. So, hey, I'm sorry, and if you want to talk offline, I'm also happy to talk about how we could try to make it better for you, your friends.
No, I mean, that's just like what I hear. It's just like a lot of vets feel like they just, from their providers, that they just get like pushed into like medications, and that they don't get like their voice isn't taken seriously. It's just like, here's some medications and go away.
It feels
Like,
like
that's
it's all
what
this
I,
problem with the pill.
yeah,
I'm sorry.
that's
And
just like what I hear a
Sure.
lot from like a lot of my friends.
You know, I think you're like, it's got to be like, care is not just pills, right? Like, it's the whole thing, and it's got to be often include therapy, often include other approaches. Yeah, I'm sorry, that's the impression. Like, that really is awful. And if they come here to the Seattle VA, I am like, honestly, I am more than happy to talk and see if we can help fix things.
I do have another question. I'm sorry.
Yeah.
So, you know, like with homeless vets, like, is there? I heard that. I don't know. Like, is there a certain like group or like style, like, you know, like there's host team where like they like specifically reach out to people who are like severely mentally ill, and then there's like lead, you know, who like they reach out to people who have like low level crimes and things like that. Like, is there an outreach team like for the VA that like reaches out to people who are homeless vets? You know what I'm saying?
Yeah, totally.
And
Yeah. I'm sorry, go ahead.
and yeah, and like that we can like refer to, like if like say like a homeless vet like comes to the day center or whatever, like we can, I don't know.
Yeah. I'm going to put it into the chat, a couple things. Let me throw it in here. So number one, you can like refer to me directly. Like, I will, I'm at Compass on Thursday mornings, except for tomorrow, but typically they're at the Compass Day Center on Thursday mornings. I'll get some more flyers and such up. We have a drop-in center down in Georgetown. That's super helpful. Like, if a veteran is homeless, they should just show up there. They can get their laundry done, get some get a shower, talk to a housing social worker, talk to a nurse or me.
Yeah, and you know, just like there's a lot of veterans who have a lot of mistrust for the VA, and you know, and how do you establish or like rebuild that relationship with veterans who just don't have a good relationship with the VA, and you know, just try to rebuild that trust. I mean,
Yeah.
I mean, to me, like that's like something that I've struggled with. You know, like I've met like homeless vets, and you know, they just like, you know, the VA doesn't do anything for me. Like they don't care. You know, I don't know. I'm just whining.
No, I mean, you're not. Like, it's legitimate, right? Like, I'm just gonna put this in I want to put this in real quick. The correct number for you. Yeah, my memory is not as good as it used to be. So this is for the Community Resource and Referral Center. It's in Georgetown. And basically, if you've got a homeless veteran, just go there. Like, just send them there, please, or call this number. You can also call me. Like, my phone number is like my clinic line. I'm going to put it in here as soon as I remember what it is.
We'd be happy to share some of these resources out post. We're recording this. We're gonna share this out with the same email list that you probably all got invited on. Yeah. And I imagine some people will want to know. I see another user who's saying that they work with Seattle Police Department and that they also find this information valuable. So
yeah,
we'll send that out. We do have two.
That'd be great, Liz.
I think, yeah, great. Yeah. With their hands raised. And you can, if you want to stop sharing the presentation so we can see each other better.
Oh, sure.
You're gonna one thing share something really quick.
One thing I'll just throw out there for you. This was like one of the reasons I like working at the VA, right? That in 2010 we decided to try to end veteran homelessness, and obviously we didn't do that, but we dropped it by half, and that's not nothing. And the VA's got more resources around homelessness than basically any other, population. So it's important. In terms of like what VA homeless services look like, we've got kind of transitional housing, we've got these rapid rehousing services, and then permanent supportive housing, and then my team, which is almost packed. But let me stop sharing for a minute.
Yeah, oftentimes we'll say, we decided, right? The nation, our system, our government decided they didn't want to tolerate veteran homelessness anymore. And they put resources and energy and people power behind it and made huge strides. And that is exactly what we need to do for the whole population, right? We need big investments that have audacious goals to move numbers like that. And we've proven that we can do it in this country. And I always find that really inspiring, seeing that, graph going down like that so quickly in such a big country with so many people and such complex systems, right?
That and that last question was really important, because that issue of trust, right? Even if you've got all the resources, even if you've got everything there, if people don't trust you, you're not going to get anywhere. And trust isn't something that is given, it's something that's earned. And you got to just keep showing up. And if the VA hasn't earned it yet, that means we just need to keep doing better. So I'll just say that piece. Other questions, other thoughts?
Yeah, Juan has his hand up. Juan?
Hello, my name is Juan Velazquez. I'm the case manager at the Shoreline Veteran Center. I wanted to mention that I personally know veterans who won't go to the Seattle VA hospital. Some go to like American Lake or Edmonds, or some go to private clinics, or obviously there are some that don't go anywhere. But generally speaking, the level of respect every veteran that has ever worked with you have for you, like the level of trust in your work and basically like in the quality of your care, is incredible to me. I've heard people talk about the VA Edge Pact, like they have superpowers. It's incredible. So yeah, I think that what you're doing with the HPAC should be replicated. Yeah, I think basically that seems to me like the solution to the situation of lack of care or perceived lack of care. I just wanted to mention that. Thank you.
Thank you, Juan. And really, I mean, it's a lot. And Shoreline, Compass, and all the other places makes such an incredible difference for vets. So anyway, thank you as well. I see Tina as well with the hand raised.
Oh, hi, Dr. Reddy. So I'm Tina Ellison. I'm the Director of Housing Services. So I think you work a lot with my managers like April Aiken and others. Anyways, I just wanted to echo a little bit of what Juan just said. And excuse my look, I just got out of a yoga class. So many of our residents, but I want to just tell you that our staff too, right, just have an immense amount of respect for you. And it's that level of trust. Like if Dr. Reddy says it, then that's the golden rule. And it takes a long time to earn that. And in what you were referring to earlier, that sometimes you get to see the wins, but sometimes you don't. I just wanted you to know that we get to see a lot of your wins, and we get to see the impacts of your compassionate care to so many people. And the fact that the staff trust your engagement and your reliability is huge. And so it just can't go unnoted. That really you kind of set the bar of the example. You shouldn't be the exception that you are, you should be the norm. And I think that the more that we have people in your profession, or all of our professions, who stand up to that level of integrity and compassion, that everybody strives to reach that. So thank you for setting a high bar of excellence. And I hope that we all continue to work together to provide that for everybody else. So,
Yeah.
Yeah.
I do wish sometimes, though, that I wish that our veterans could sometimes see what it looks like hear some of the conversations, right? Like the way that we talk, like in the workrooms or conference rooms. like the level of care that my colleagues, like both nurses and doctors, like, excuse the language, but at least the vast majority of the people that I get to work with really give a shit. And I know sometimes that may not come across, but I wish they could sometime, I wish other people could see it in the same way that I get to see it. So anyway, I see Anita's hand up as well.
Oh, and I think there was another, Mac was before me.
Oh, sorry.
Is that-
I'm not going to be long. This is Maya. I'm a community service officer with the Seattle Police Department. And so this is really great getting this information because we, with our job is to assist officers for them to do more emergency issues. And so they come across individuals who are on the street, and we also come across on our own. And so we do come into contact with vets who are homeless. Like we have an individual now who's a veteran, and he's in a wheelchair. And so it's been difficult trying to find, I think the other supervisor, because I'm one of the supervisors, they've reached out to the VA and it hasn't been much luck. So, I mean, if I'm able to get as much, information that I can pass on to the team, just to assist, because we deal with homelessness a lot in our position, and we do come across veterans all the time. And it feels so unfortunate when we can't find them services when, we know there's a VA hospital, but for whatever reason, sometimes some people are in a state where they can't give us their name or give us a social security to be able to see if they're, where they are in the system. So I'm just appreciative of this information. So as much as, you can provide, and if you can be a resource for our unit, that would really be great.
100%. Yeah. If I can give my info to Liz to pass along, that would be, if you can contact me directly, that'd be great. I really appreciate it.
So thank you.
Yeah, and there's no specific outreach worker that specializes in outreaching homeless vets. No,
So that's me.
that's not a
actually.
thing.
No, it is a thing. So there's several different people. So I am one of them. So my team focuses on seeing patients both in clinic, but in outreach too, right? So
But in crisis,
so
outreach in crisis.
right. So there was a veteran in crisis that, heard about this morning and went to go visit. So I'm not on call 24 hours a day, but if you can talk to me about somebody that you're worried about, happy to come out and visit.
Yeah, Dr. Reddy, I think one of the things I've heard passed along from program managers as I've, just worked alongside them over time is, if they have a veteran in the building or in that's, stumbled into the day center who's in crisis, they're able to make that call and make that connection. And you're quite
right. It's not just me. I want to be clear. It's, we have essentially this homeless primary care program called HPACT, and it's a group of a few nurses, doctors, social worker, and we really try to coordinate care. So let's say somebody's at the Crisis Solution Center, they will usually call us and let us know that they've got a veteran, and then we try to coordinate care after, for example. Likewise, that CRC building has a number of social workers who are dedicated to connecting with veterans experiencing homelessness. So they may come out to a shelter or go to a, encampment or wherever it may be.
We've got Anita and then Megan, and then we're going to wrap it up, actually.
Okay, thanks so much for this presentation. And I may have missed this information in your presentation, but what is the percentage of VA veterans who are homeless of the total population?
I don't remember off the top of my head exactly, but so the word veteran, in fact, in VA are kind of a complicated subject. And I know that sounds weird, but not everybody who's served in the military is eligible for VA healthcare benefits.
Okay.
But then a different group is eligible for housing benefits. And it gets really complicated really fast when we're talking about veterans and eligibility and services and that kind of thing. But in general, like in terms of self-identified people who self-identify as veterans experiencing homelessness, I think the number is like in the 7-ish to 10% range.
Oh, okay.
Historically, people who are veterans have a 2 to 3 times higher kind of what they call odds ratio of becoming homeless than someone who's not served in the military.
I just
But-
have to say, I think somebody's failing our veterans in big time, and which you probably all know. So thank you for your answer.
Sure. And Megan, I think.
Hi, I'm Megan Sarver. I'm the program coordinator of the Renton Veterans Center. I just want to echo again what Tina and Juan mentioned about you first off, and then the HPAC team in general. I heard about you well before I was involved with HPAC, and only ever good things. Like our veterans have nothing but kind words to say, and you've been incredibly impactful for every one of them. But the HPAC team is something that I've really cherished getting to work with. And when we've expressed a need for something, they've responded. So we mentioned like we would like some mental health counseling, and we've got a lot of people facing substance use and things like that, and HPAC responded immediately. So now we have a primary care provider and who's also a addiction treatment specialist, and then we have a a psychiatrist, Olin. I think you're familiar with him as well. Yeah. So HPAC has just been such a wonderful thing, and we literally have them out every month to our building, and HPAC has made it so all of our veterans who had not been connected to primary care in over a year were able to get connected. And so I couldn't speak more highly about your guys' team and all the work you've done for our veterans. So thank you.
Really appreciate that. It's a really awesome team to get to work with, and the VA gives us a lot of flexibility to try to connect with people. So I do want to mention one thing in the chat though. It's not that 7 to 10% of veterans become homeless. I'll have to look up the number. I was trying to reference the percentage of the people who are homeless who are veterans, which is a little bit different. Okay.
Yeah, I saw that Brown had their hand up and had earlier shared in the chat as well.
Hey, Eli.
Hey, what's happening there, sir?
Good to see
As
you.
a veteran who receives services from the HPAC and from Compass, I remember when Dr. Reddy's team would be out at the building providing services to veterans who were scared or apprehensive about going into Seattle because of past treatments there. So the ability for them to change their schedules and address us at our level was incredibly important, because there were a lot of people here at the time who would not have gotten medical care if a provider didn't come on site to where we were. So things are changing. The people who have been run off from the Veterans Administration maybe about 10 years ago, you might want to think about having to come back in and be reassessed, because the way they're treating us is a little bit different than what they may be accustomed to. So I appreciate the hell out of you, Dr. Reddy, and so many other veterans in this building do as well.
Right back at you, my friend. Thanks for sharing.
That was really sweet.
Thanks a
Thank
lot.
you for sharing. And Brown had also put in the chat that, this type of care for family and self, literally meant the difference between life and death. And, when we talk at Compass about housing as healthcare, and to your point about, bringing services on site and how key that is, we really mean that marriage makes a huge difference. And we would love to see that grow and the trust grow for that, right? It's so wonderful. So I know we need to wrap up. This has been such a wonderful conversation, and I know not necessarily an easy one. Dr. Reddy, hit us with some hard facts, but this is why we're here. We want to engage in this issue. We want to understand the issue, and we want to find our way through being a community participant in the solution. And so I really thank all of you for joining us tonight and taking the time out of your evening. I just so appreciate you all being here. The recording of this event is going to be available for you to share, along with information about accessing veterans resources. That will likely be out early next week. That will come by way of our eNews. So if you're not signed up for our e-newsletters, Nathan's going to drop the link in the chat. All we need is your name and your email. And you'll be sure to get that recording and then other information from Compass as things go on, along with more information about the next Navigates. The next Navigates will probably be at the end of December or early January. We gotta kind of figure that out. We're in our first year of this program, but do stay tuned for that information. And then we're also really interested in your feedback. So Nathan's going to drop a link in the chat to a really short SurveyMonkey survey. We want to hear your feedback about how we're doing, where we're going, and what we can do better, and also focus on in way of topics. So I would appreciate your feedback there. I think that's all I have for tonight. So thank you so much for being here, everyone. And thanks again to Dr. Reddy.
Thank you, everyone. Really appreciate it.
All right. We'll keep it up in case you want to click on that survey or email, but y'all are free to go. Enjoy your evening.
Liz, thank you. What a great day.
Oh, yeah, you're welcome. No problem. And thanks to Nathan and Anne as well. All right, and Dr. Reddy, I do see that the community officer, Mia Mack, had noted her email in the chat. So I'm gonna copy that and paste it over to you in an email.
Oh, thank you. If I give you a PDF of a flyer, could that go up somewhere?
Yeah, that would be great. We can link to that in the follow-up. I think the follow-up will probably go out early next week. We're a couple days behind on some other projects, so.
Great, then I can just email that out to you.
Yeah, great.
Cool. Hey, thanks for being here.
No, thank you for doing this. I know I hear legend of how busy you are. So thank you for saying yes. Thank you for taking time. I hope it was valuable for you too. And Brown, thank you for sharing. That was really lovely of you to share. So thank you.
Thank you for listening. Thank you, Nathan. Thank you, Dr. Reddy. You're the man.
Give my best to Jackie too.
Most definitely, sir. Have a good one.
All right,
All right. Have a good night, everyone.
Okay.